session. Let me invite Dr. Shashank Ashili for his presentation now.
Yeah, sir, before
Yeah,
that, just me introduce Dr. Shashank Ashili.
please.
Yeah, he's also one of the co-organizer of this event. Dr. Shashank Ashili is a scientist, entrepreneur, and founding CEO of Cure Science. He led the organization in forming global partnership and innovative projects, including the Apomix initiative on wearable and apps. He is a strong advocate of patient empowerment. He established patient-centric resources at Cure Science and focuses on personalized and precision medicine, especially in longevity and quality of life. Dr. Ashili investigating and improving science and healthcare access in Asia, primarily in India. His research contributions are reflected in numerous publications and esteemed scientific journals. So thank you, Dr. Ashili, for agreeing to present your talk in the plenary sessions. Over to you, sir.
Thank you, sir. Please allow me to go through the technical challenges. I hope, can you guys see my screen?
Yes. Yeah.
Or do you see everything else? I'm only sharing the PPT. Can you guys see that?
Yeah.
Okay,
Please.
great.
Is it on the
Thank you.
presentation mode slide? Yeah.
Okay. Just want to make sure, is everything good, right? Okay. All right. Thank you so much, Professor Bansard. And let me just touch on Professor Gangadhar and Dr. Gangadharan's points. Few things, sir. Now I'm 50. I want to consider myself 30. So age is just a number. That's one. And I think this is a longer conversation. Old age homes. I just want to say that there is a taboo, especially in South India. People going into old age homes is really, really considered as a taboo thing. I had to deal with that by my parents. Fortunately, the old age home was right in our village, and yet they resisted. But I have to tell you this, I have to tell everyone this, once they joined there, they resisted as much as they can, but once they joined, their social life improved dramatically. And not only their social life, their activities and everything improved dramatically. It had been a very, very different lifestyle once they joined. And another thing, abuses, sir, you touched on abuses, and I'd seen this, personally, financial abuses, that had been a real challenge, share the OTP abuse kind of a thing, especially with the old people in India. Thank you, sir. Thank you so much for your insight. With that, let me jump into my conversation on the digital medicine. So as I mentioned in my introductory remarks, I am much more focused into the digital medicine side. And for this presentation, I was more thinking of how do I put contextually digital medicine. And that is where, one of my interests is P4 medicine. As many of you know, P4 medicine, it was proposed in sometime in 2013 through the seminal paper from Leroy Hood out of Seattle. And it's very simple, but it makes so much sense. It's for each P stands for predictive, preventative, personalized, and participatory. And this conversation, as you can imagine, predictive, early identification of disease. We all spoke about all these, in different contexts, but putting the framework together is real meaning of the P4 medicine, identifying the disease early on and then targeting the strategies for prevention once you identify. So all those requires, obviously, patients coming forward or having regular checkups. Those are very important, but, depending upon the healthcare system, depending on the payers, it changes time to time. But most importantly, I want to take this presentation into personalized and participatory side of the conversation. As you can imagine, whether it is diagnostics or therapeutics, right? Focusing on individual is much more important and trying to understand what their health is trying to tell you, what their disease is trying to tell you, but at the same time, keeping the lessons that we learn from the collective, whether it is diagnostics or therapeutics or quality of life. So that is much more important, and that is an upcoming. And not so upcoming, or it's still in the sidelines, is the participatory component. Participatory component where the conversation is much more about involving the patient in their decision-making, clinical decision-making. It's very easy to say, but participatory medicine is what I want to focus on. It's real challenging. As you can imagine, patients and their families are going through this distress, whatever that disease is. If it is a chronic disease, obviously the management is a little bit better than incidental diseases like cancer. But if it is a cancer, then all of a sudden you are in distress. The whole family and the social network is in distress. But what we realized, is yes, they are in distress, but with the right tools, we can make some changes. And that is where, the P4 medicine, the way I see it is, it's a decentralized activity, and there is much more room for digital medicine than it had been acknowledged so far. And that is where I want to show some of our activities. As we discussed, there are four P's. Obviously, in the predictive side, you're looking at, all kinds of genomics. Chronic diseases prediction is almost easy, relatively easy. But when it comes to, advanced diseases like cancer, genomics or some kind of omics will step in and advanced testing. And there comes the access part as well. And then on the preventative strategies, very often the preventative strategies are simple, very often, but on two sides of the spectrum, the simplicity is one side where we can prevent many of the chronic side, but on the aggressive side, surgeries, for example, BRCA gene and double mastectomy, you will get that side of activities as well. Again, and getting into personalized side, this is where, one of the biggest challenges, omics-based therapeutics. And I personally encounter a lot of challenges with this in India with my parents, and then there is a participatory component. Here, one of the biggest challenge I'd been on the flight decisions. I'll walk you through what I'm talking about, but also compliance side of the patients and their family. That had been a big challenge. As you can imagine, this cannot be done by a single vertical, whether it is a provider, the doctors, or whether it's the patients and the family, or whether it's a payers. This is a culmination of scientists, providers, and the family, but also the payer. Somebody got to pay. Here in the US, we refer to them as insurance, but in India, there is insurance, and I went through my own challenges with them. What I realized is I'm better off without insurance in India, because of the paperwork I need to submit, because of the number of times I had to call them and have to get approvals. It was just not worth it. But again, these are my experiences and I wanted to share. So how can we get into the granularity of P4 medicine? So I took a shot at it. It is still evolving. What we call it as is a parametric profiling. What we want to look into is one side, you have the healthcare side of the equation. The other side, you have the digital side of the equation, where engineers and scientists from physical sciences and social sciences will come in. On one side, you have the providers who are the doctors. And then there is a component, that emerging component of multi-omics. But with multi-omics, one of the biggest challenges, the resources and the access and the costs. So that had been a big challenge. But and I want to focus more on the apomics side, where you have all kinds of data sets that you can put in, whether it is smartwatches, CGMs, or whether it is environmental, and the CGMs had been a God's gift, I have to say. At least in my case, it had been a God's gift. So how do we put all this together and bring that knowledge? Internally, this is what we refer. We refer them as a dynamic data set and a static data set. Static data set is simply your genomics, your healthcare records, because those are probably every 3 months, every 6 months, every 1 year. They don't change every day. But in the apomics world, where you have all these devices and environment and dietary, these are day-to-day changes. And that reflects on your quality of life day to day. So these dynamic decisions are very critical. And that is what I want to showcase today. That slide, how granular we want to go in this dynamic side of the world, and also the static side of the world. And in the static side of the world, as we mentioned, multi-omics, you can name any omics, we can get that data set. But again, it's going to be a static data set. But again, if you are looking into granularity on the dynamic data sets, there's a lot of changes. I'll give you my own example. I wear 2 smartwatches all the time. One is Withings, one is Fitbit. And I've been collecting my own data for the past 4 years. One thing I noticed, consistently, whenever I'm in India, my temperatures, my HRVs are high, no matter what, no matter what. And our team noticed that, and they are like, why is it happening? We are still exploring, but my point being that granularity has some value. And that value is important as we look into quality of life, as we look into day-to-day life, and as we look into making some of the dynamic decisions. And that is where the participatory component comes into picture. I understand there are many startups coming in especially in the CGM space, where they are using all kinds of fancy buzzwords, if you will. One of them is AI generated insights. All those are great, but how far we want to trust AI generated insights versus a lab tech or a provider looking at these and making the decisions on the fly. So I tried to look into this. Initially when I started looking into this, I was like, is this necessary question to ask? And as a scientist, one of the key things what I do is every time there is a question, I try to prove it false or true, whatever it is, and that's what I did in this case. So I'm going to present a case study to you. We have a patient, stage 4 cancer patient, chronic diabetic, rural village setting, 80 kilometers from Hyderabad. So no accessibility, nothing. How can we do with this patient? How can we bring the P4 medicine and put the digital medicine at the forefront? And the approach was obviously immuno-oncology. This was 3 years back. At that point, immuno-oncology was very new in India, and opportunities were very less. So there had been tremendous challenges from the providers, and more importantly, testing and therapeutic challenges. So we were unable to find the testing, their sample acquisition. So every step there was a challenge. And then on the participatory side, on the ground challenges, primarily the knowledge. One of the biggest thing, as you can imagine, whether it is rural or urban, one of the biggest thing when it comes to these kind of decisions, it's a scientific knowledge of the patient and their family. Very often, the other day I was looking into some stats, how many people are scientists in this world, and obviously it is less than 1%. So, scientific background, you cannot expect patients to have scientific background. And then there are therapy-related challenges as well. Science or medicine is not available, so you're supposed to wait. How long, we don't know. And then chronic diseases. These are one of the, as much as people want to think, I'd seen a lot of advertisements when I was in India as well, that they're reversing diabetes. Whether it is true or false, scientifically, there are very limited number of cases where the diabetes had been reversed. But these are, again, marketing words, right? So it's a false impression that had been going on. And very often patient complaints will make a big difference. They are like, I have a person who is telling me that they are going to reverse diabetes, and you're telling me that it cannot be reversed, and it's very hard to reverse, but quality of life, they are always going to go there. So, and then we always have our, our own traditional activities as well. So all this comes into, when we are dealing with patients and their families. So the way we try to solve in this is trying to bring the offshore folks, and we brought the offshore providers, the doctors who are at the forefront of the genomics and other multi-omics. And then we brought the team of bioinformatics as well. But one of the biggest challenge was, since the patient was in India, sample acquisition and further sequencing had been one of the biggest challenge, one of our biggest challenge. But we figured out, but we started putting things together. And then on the participatory side, as I mentioned, remote. So what we engaged in is, we had a lab technician, and all they had to do is, give XYZ medicine, color medicine, or this medicine, or that medicine, but take vitals and keep us updated. And then we had a team looking over them remotely, what they are doing. In addition to that, we had smartwatches, CGMs. So this all brought up, it took some time to train the patients, but it all brought up so much data to us. And that really, really gave us a chance into looking into what exactly we are going to do with this data. I mean, obviously we had our own thoughts on what we want to do, but that is still, we are still publishing, we are still going through the data. But one important thing that came out of was, a successful activity. I'll give you an example of what I'm referring to. Diabetic patient, they go to a doctor in India, they'll tell you, if the patient is on insulin, hey, take 10 units in the morning, 10 units in the evening. What they did, I mean, that is the collective information. I'm not pointing finger at them. It's a collective information, because they obtained that information over the years, and there are research papers showing that it is correct. Whatever the 10 or 11 or 12, whatever the numbers, it's working. But what happened to the hypoglycemia situation? And that was obviously never, eat a spoon of sugar, your hypoglycemia is gone. But what we were able to do was we kept the insulin in the morning as a constant, but we started changing the insulin in the evening. So with that, we essentially came out of hypoglycemic situation forever. There was no hypoglycemic incidents, and every time there was a hypoglycemic incident, as you can imagine, the patient was a chemo and immunotherapy patient. So there are a lot of challenges. It's an amalgam of things. You don't know which one is causing which. But thanks to CGMs and the digital medicine and the team, we were able to take out that. And once we took out that from the conversation, the quality of life improved dramatically. I mean, we did not have any hypoglycemic incidents. So this is the one component I want to highlight in the perimetric profiling, and in the end, this is what we learned. Cost, it is super costly, because you have to pay for so many folks, and you have to pay for the devices, and there are a lot of things that you need to. And logistics had been another biggest problem, obviously, as you can imagine. Local employees. I'll give you an example. When we started all this, we wanted to have a full-time nurse, and we spoke to multiple people. And what we realized is none of them come with a background check. And as you can imagine, without a background check, it's risky. So, all these things, right? Local challenges are too many. But is it worth it? I'm very confident that it is worth it, but it needs a collaborative approach. You cannot do it as a single person, or we cannot do it as a single entity. So when I say collaborative approach, collaborations between the scientists, along with the bioinformatics folks, but also collaborations with the data science folks, but also the providers and the local knowledge. So, but all this together, you can literally change the quality of life dramatically. And the example is this patient. So you will be seeing some of our papers coming out of this, but that's what I wanted to share today. And thank you so much. And I want to thank our collaborators, Renix team, Dr. Divya Ramakrishna and Mrs. Chaitra, who had been on the forefront as a remote team, monitoring everything on the ground and making on-the-fly decisions. Sometimes there is I'll give you one example, based on smartphone data, we can monitor the mobility. If the mobility is low, then obviously sugar will be high. Their glucose number will be high. So and if the mobility is high, then obviously the insulin needs to be low. So all these on-the-fly decisions, thanks to them, we were able to do that. They were monitoring constantly, and the logistical pipeline was optimized. And then on the back end side, Dr. Vijay Padal and Dr. Nupur Biswas. Dr. Biswas is not with the Renix anymore, but they had been tremendous help, whether it is building the bioinformatics pipelines or whether it is looking into the digital medicine side. I want to thank everyone, my collaborators, and everyone at my team at Q Science as well. And with that, if you have any questions, feel free to ask after the session. And thank you so much. Thank you, Professor Shekhar.
Thank you, Dr. Shashank, for a very interesting presentation and very interesting research your team is doing and improving the quality of life of elderly. Even a smartphone can make a big difference. And I see some of the very interesting findings.